Okay, guys, welcome to today's. Wait, how do I set this up? Okay, guys, so today we are doing. Oh, there's insufficient light. Wait, let me just find another place. Okay. We're going to be studying hypothyroidism today, and wait. I think this much light is enough. Great. So, okay. What was I saying? I was saying that today we're studying hypothyroidism, the guidelines that are given by Rcog. I will not be going into the details of the trials. I will be helping you out with understanding the recommendations. Okay. So, there is subclinical hypothyroidism, there is overt hypothyroidism. Subclinical hypothyroidism has a risk of converting into full blown overt hypothyroidism in pregnancy. Okay, and this subclinical hypothyroidism in pregnancy is related with pregnancy loss and neonatal death. And if we give levothyroxine, in subclinical hypothyroidism, then it would reduce the rate of pregnancy loss and neonatal death. Okay? So now we're going to start with the recommendations. The first question is that a woman who is diagnosed, she's diagnosed with hypothyroidism. सबसे पहले हम शुरू करेंगे pre-pregnancy से. We're going to start with the pre-pregnancy time period first. Okay. Even for hyper, you first should know the pre-pregnancy, and she is diagnosed right now and she wants to conceive. So what are you going to do? You're going to tell her to conceive? No, you are going to check her levels. Okay, so if she has, this is an equation, guys, just like maths. Okay, please pay attention. If she has subclinical hypothyroidism, then you're gonna see your target should be a TSH of, kindly give a guess, what should be the value if she wants to conceive? What should be the value? It should be less than or equal to 2.5. Okay, this is the value, milli international unit per liter. You guys should know this. This is the target. If she wants to conceive, this should be achieved before conception if she's a known case of subclinical hypothyroidism. Now there are two scenarios. Okay, this is a target. The scenarios are that if the TSH, so in this case the free T4 will be normal or in the upper normal range. It will not be that much deranged because it's subclinical, right? TSH will be largely deranged. Okay, so TSH is more than 10, and the second scenario, TSH is less than 10 but more than 2.5 or the upper normal value for that trimester. Trimester wise is also a term that they are using. So in the first scenario, when the TSH is more than 10, of course you're going to start levothyroxine. Okay, in this scenario I'm not talking about the clinical condition or the clinical picture. Right now I'm talking about the lab values. Okay, so in this case, when the TSH is more than 10, then you're not supposed to ask any more things to start levothyroxine. You don't need anything else because the T4 is going to be normal or in the upper normal limit. So over here you're going to start levothyroxine right away. Okay, start levothyroxine at more than 10. But if it's in this range, it's less than 10 but it's also more than the target, outside the target, it's more than 2.5, then in this scenario what are you going to do? Please, any answers? In this scenario you should consider levothyroxine in those scenarios where TPO antibody is positive. Okay, should consider The guideline is saying this line that you guys should know this line as it is. Should consider levothyroxine, particularly if TPO antibodies are positive. TPO antibodies, I will discuss, they have a very important role with an abnormal. You should remember that TPO antibodies is very much related to this. If TPO antibodies are negative and this is the value, then you can also choose not to treat. It depends on your clinical assessment, on your local protocol. But with this value, because this is a gray zone, right? This is the white zone. This is where you're supposed to let her conceive. The target is achieved. This is the black zone. This is where you are supposed to start levothyroxine and try it such that your target is achieved. And this is the gray zone. And this gray zone needs a positive TPO antibody for starting levothyroxine. Otherwise, it depends on your own clinical assessment. Otherwise, it's not totally recommended. And at the end, your target should be TSH of 2.5 or less than that. Okay. Now, in a scenario where there is isolated, where it's opposite, where the free T4 is low, okay, and where so now to secondary cause and TSH, this she's taking her treatment and her TSH is achieved and she conceives at the same time and her UPT becomes positive, then now what are you going to do? In this case, you are going to titrate her dose such that, how can I titrate it? Basically, the target is, let me just make this clear. I'm going to speak the sentence, not write it down. Within 5 weeks of conception, you should increase the dose 25 to 50%, out of which 25 to 30% increase should be done. It can be done by the patient herself. सबसे आसान चीज़ होती है जो पेशेंट्स करते हैं, जो एंडो वाले करवाते हैं कि वीक में 2 दिन डबल डोज ले लें, ठीक है, वीक में 2 दिन डबल डोज ले लें, या फिर ये कर लें कि अगर उनकी डोज 100 माइक्रोग्राम से कम है या 100 माइक्रोग्राम से ज़्यादा है तो फिर आपने क्या टाइट्रेट करना है. अगर उनकी डोज 100 माइक्रोग्राम से कम है तो आपने 25 माइक्रोग्राम बढ़ा देनी है, और 100 माइक्रोग्राम से ज़्यादा है तो आपने 50 माइक्रोग्राम, ये पर डे के हिसाब से. तो देखिए ये ज़्यादा डिफ़िकल्ट है, इसलिए ज़्यादा प्रैक्टिकली मैं बता रही हूँ, आपको आना चाहिए. प्रैक्टिकली पेशेंट्स ये करते हैं कि वीक में 2 दफ़ा डबल डोज लेते हैं. तो ये थी हाइपोथायरॉयडिज्म की मैनेजमेंट प्री कंसेप्शन. शी हैज़ नॉट कंसीव, यू आर प्रिपेयरिंग हर फॉर कंसेप्शन एंड देन शी कंसीव्स ड्यूरिंग ट्रीटमेंट. तो आपने क्या करना है? अब नेक्स्ट जो सिनेरियो है कि नाउ शी डायग्नोज ड्यूरिंग प्रेगनेंसी. तो उस सिनेरियो में हम क्या करें?